Okay, good morning. Good morning. I'm Peter Wyman. I'm co-director of our department's Suicide Prevention Center. A couple of housekeeping items first. For those of you who are on Zoom, please use the Q&A channel for questions. We'll try to get those at the end. There's also the survey at the end as well. So our grand round speaker today is Brent Kious. Brent earned his MD and PhD in philosophy at UCLA. He is associate professor of psychiatry, adjunct professor in the Department of Philosophy, and core faculty in the Center for Health Ethics, Arts, and Humanities at the University of Utah. Brent's research in bioethics focuses on ethical issues in psychiatry, including the role of values in psychiatric diagnosis, the nature and moral significance of suffering, medical aid in dying in psychiatry, what palliative care would look like in psychiatry, and the ethics of suicide prevention. Dr. Kious has won numerous awards and accolades for his work. He was selected as a Laughlin Fellow of the American College of Psychiatry in 2015. In 2017, he was awarded a Young Investigator Grant from the Brain and Behavior Research Foundation, and he was a Greenwald Foundation Faculty Scholar in 2023. In addition to all that, he currently practices adult inpatient psychiatry at the Huntsman Mental Health Institute in Salt Lake City. Dr. Kios's visit here is very timely, given the recent passing of the Medical Aid in Dying Act in New York State. Brent's been very generous with his time. He met with our center, Suicide Prevention Center group yesterday, and our 232 fellows. He is a thoughtful and thought-provoking speaker, and please join me in welcoming him.
So I am kind of trying out this material. This is something that I've started to think about recently, and I really want to raise the questions that I'm going to raise in the spirit of fostering discussion. So this is like the big caveat about this talk. I'm not sure about any of this stuff, but I am going to try to ruffle some feathers, because my feathers are ruffled and I want everybody else to be worried about the same things I am. Just some quick disclosures. I have research support from Abbott. And because what I'm going to say is maybe a little bit controversial, and there are folks at my institution who might not like it, I'm just going to say they don't endorse it in any way at all. So they are fully exculpated if this goes badly. Those are the learning objectives. Those are kind of boring. We'll skip them. So again, the spirit of the argument. I'm going to problematize or try to problematize the way we approach suicide prevention in this country, or at least some aspects of the way we do so. But I'm doing that as an inpatient psychiatrist. Probably 60% of my patients are admitted with significant suicidal ideation. I think suicide prevention is often very important clinically. I do some research about suicide prevention, not just ethics, but I work with our local crisis line to evaluate how it delivers services to teens who are suicidal. And in spite of that, and maybe, in fact, because of a lot of my clinical work, I'm really quite worried about what we do, and I want all of you to worry with me. And I should say, you're going to see a lot of Rothkos and some other artists here. It's all in the public domain, no copyright issues. So a quick outline first, just to whet your intuitions and to get you thinking about how serious these questions really are. I'm going to compare two cases. Then I'll do a little bit of philosophy and invite you to think with me about what actually justifies our efforts to prevent suicide right now. What's the fundamental moral justification for what we do? I will then talk about some more technical worries about how good we are or aren't at predicting suicide and preventing suicide, and in light of that, whether we should maybe change our current approach. And then I'll end, time permitting, by saying a little bit about what might actually make a suicide prevention approach more morally permissible or more desirable. So here's a case, and this is a case with which, unfortunately, I was personally connected. Let's call him Will. Is a 14-year-old boy who is almost finished with the 8th grade. He is a smart kid who is popular. He's doing very well in school. He's very athletic. He has a lot of friends. He has a girlfriend, maybe a little too young to have a girlfriend, but he does. He has a lot of hobbies, likes to play basketball. His parents are great folks. They're loving, they're spiritual, they're not abusive. He doesn't use drugs, doesn't really have a lot of bad habits. Unfortunately, he is sometimes depressed. He is treated by his pediatrician and by a therapist. He takes an SSRI. He often feels overwhelmed by what he perceives as his personal inadequacies, and he sometimes thinks it would be better to die than to risk failing in life, right? So he's got a really bad case of perfectionism. He has expressed suicidal thoughts to his parents and to some of his friends, but he's never engaged in any suicidal behavior. With all the treatment that he's getting, Will actually starts to be doing a bit better. He's happier. He's not talking about hating himself. He's not talking about wanting to die. But his parents are appropriately concerned, I think. They do all of the usual things. They get rid of the handgun that they have in the house. They lock up medications. They get rid of all the acetaminophen. They keep a close eye on him, picking him up at school every day rather than letting him walk home. And they track his location with a phone app. Of course, all parents do that now, I think. And one Tuesday in the spring, he has a great day at school. He is laughing with friends. He is playing basketball in the gym. Holding hands with his girlfriend at lunch, and he wins a math Olympiad. And to make a long story short, that afternoon, he puts his backpack in his locker, skips school 30 minutes before his parents will pick him up, and dies by suicide in the mountains. So I think it's obvious from my emotional reaction that I think that Will's suicide was tragic and undoubtedly worth preventing. I think it's less obvious what we could have actually done to help it, right? Everybody was doing what they could do, and he wasn't actually giving signs at the time that he died that he was at high risk. Now I want to contrast this with a somewhat different case. One of my patients. John is a 57-year-old man who has depression and alcohol dependence. He's just learned that he has gastric cancer. His wife divorced him 12 years ago. He's out of contact with his adult daughters. They've refused to talk to him for around 8 years. He used to work as a welder, but because of his alcohol dependence, he's lost his job and he has been on unemployment. And so his finances are already tight, but now he worries that his unemployment benefits are going to get terminated. So he's not sure that he's going to be able to afford his small apartment and is legitimately worried that he is going to be homeless. In some contrast to Will, John has been through a lot of psychiatric treatment. Before he got divorced, he started trying to get sober. He went to the hospital several times for detox and then to residential treatment, a total of 5 times with over 190 days of residential treatment. He has had multiple medications to reduce his relapse risk. Naltrexone, gabapentin, acamprosate, all of those things that we try. He's been to AA, doesn't like it very much. He has tried individual therapy intermittently for over a decade. Most of the time he's drinking while he's getting therapy and doesn't necessarily adhere to the medications very well. Every time he's finished some treatment, especially after residential treatment, he goes back to drinking within a week. So he sees little reason to go on living. He doesn't see fighting his cancer as worthwhile. He doesn't think that there is anyone who will care very much if he dies. And to be honest, knowing him, it's actually hard to argue with him about that. There's not much that he enjoys in life. He doesn't think that he can tolerate being homeless, especially if he is trying to get treatment for cancer or just dealing with the cancer. So he decides to end his life, and somebody's calling me. That's weird. And sends a text message to his therapist letting her know that this is his plan. It's kind of a last minute thing, and then he dies of suicide at home. So I think these two cases are quite different. You might disagree. I believe in practice, you disagree. I know you do. Kim and I have had some disagreements. It's all right. I think these are different cases, but importantly for our purposes, it's pretty clear that apart from the different clinical considerations with respect to medication and the kinds of interventions we would offer, we would often treat them exactly the same way. If we knew in advance that both of these individuals were seriously planning to kill themselves, we would probably bring them to an emergency department. We would admit them to the hospital. If they weren't cooperative with treatment, we might treat them against their wishes. What I want to know is, should we do that? So now a little bit of philosophy. I promise I won't cry through this part. You might. In modern mental health care, I think we assume that preventing suicide is an ethical imperative. What justifies that assumption? Here, I'm just going to quickly review a variety of arguments a person might make and then evaluate them. One argument refers to the sanctity of life. Many of us think that human life is sacred, which is to say that we have a moral obligation to do everything we can to protect and promote it. And it's clear that human life is, even if you don't think it's sacred, very, very important. There are also, of course, many religious traditions that regard life as sacred, treating it as a gift from God or a sacred responsibility that God has conferred on us. But against this view, if you're not a spiritual person, if you don't accept the religiously informed view that life is sacred, you might actually find it hard to accept that life is truly sacred. And I would note, we often behave in ways that assume that life has finite value, which is not compatible with its being sacred, where it would have infinite value. So just some quick examples. We limit what we spend on healthcare. We limit what we spend on measures to protect people from accidental death. We make compromises with respect to things like speed limits. And we permit people to work in jobs where they have a relatively high risk of dying. Another thing you might think is just that killing is wrong. It's clear there is a general moral prohibition against killing. Murder is wrong. And some scholars have argued that suicide is actually self-murder, in which case it would also be wrong for the same reasons. But against this argument, it's clear that killing isn't always wrong. We can do it in self-defense. We can do it in just wars. So the question we really have to grapple with is, when is killing actually justified? And if it's not always unjustified, is it possible that some of the considerations that lead people to suicide could justify it? And I would note, there are even clear examples of permissible self-killing. If a soldier who wouldn't otherwise have died jumps on a grenade to save 5 of his comrades, I think that's suicide. And I also think that's morally permissible and no one should have tried to prevent it. Another obvious consideration is potential harms to the victim. For many people who die of suicide, Will, I think, is a very clear example of this. it's plausible that with treatment and support, they could have had lives that were worth living. You know? Suicide means that they lost that potential value. Again, though, this is only true sometimes, or so I think. What about the possibility that there are some people for whom continued existence by their own lights seems a net negative? Some of you I know, Kim, disagree with this even being possible, and I'd love to talk about that. Harm to others is a really important consideration. If somebody dies of suicide, it often will harm their family and friends. It certainly harmed Will's family and friends. It will cause them emotional distress. It may increase their risk of suicide. Some studies I've seen suggest it could be as much as 25-fold. It will mean lost resources if the person who dies was a caregiver or a provider. Again, though, this is just true sometimes. What about the person on whom others do not depend? And is it even possible that for some people, their continued existence is actually a net negative for other people? The argument that might be the best, in my view, and which I suspect animates a lot of our clinical work with respect to suicide prevention, is what I'm going to call the medical argument. So some have suggested that suicidal behavior is essentially pathological, almost always representative of some underlying disorder, a mental disorder, of course. And if you're interested in that idea, I recommend Dominic Sisti's work on this. You might also think that physicians are obligated to prevent harm to their patients when that arises from a pathological process. Death is usually bad, maybe always bad, other things equal. And so it seems to follow that physicians are obligated to prevent suicide death and thus to interfere with suicidal behavior whenever it arises. Unfortunately, this argument, although it needs a lot more unpacking than the earlier arguments, I think also is unpersuasive. First, the evidence that suicidal behavior is pathological is surprisingly weak. Craig Bryan has a great book about this. I really recommend it, Rethinking Suicide. One thing I would note is that in some studies, only about 50% of people who ultimately died of suicide, and this is research we've conducted at the University of Utah, had a previously diagnosed mental disorder. And of course, some of those who didn't have a diagnosis may have had a disorder and just didn't come to clinical attention. Bryan points out that the primary evidence for the claim that suicidal behavior or suicide death is typically associated with mental illness comes from psychological autopsies, but makes a pretty compelling case that many of those studies are biased. One reason is that there's sort of a tautology in the link between suicide and mental illness. Since suicidal ideation and behavior are part of the criteria of several DSM diagnoses, having engaged in suicidal behavior makes it much more likely that you are going to receive that diagnosis. Another thing I would point out, and this is more of a philosophical point, is that even if someone has a mental illness, it doesn't guarantee that their suicide death is a pathological consequence of that illness. So here's a sort of toy philosopher's example. Imagine that Derek has panic disorder. A terrorist doesn't like Derek very much and tells him that he will detonate an atomic bomb in New York City if Derek doesn't kill himself. And Derek very reasonably, because he thinks the threat is credible, decides to kill himself. Here, the panic disorder just seems irrelevant to Derek's decision. A somewhat stickier case is Virginia Woolf. She died of suicide. She probably had bipolar disorder. And as far as I understand the story, between episodes of mania and psychosis, she was quite concerned that she was going to become sick again, wasn't obviously depressed, wrote several letters to her husband explaining her plan to die, which he received, and he did not intercede, and then ended her life. Here, I don't think that the mental illness was directly causative of Virginia Woolf's death, but was maybe indirectly related to it. Here's maybe the most controversial reason I have for worrying about the medical arguments. I think sometimes it's possible that death is not a net harm. It's possible that a person's life has become so bad that they reasonably see it as not worth living. And so here I'm thinking of people with severe and chronic disabling pain, persons with terminal illness who might be eligible for medical aid in dying, and perhaps even John from case 2. So what I want to drive home is that I'm not aware, although we might talk about this in the Q&A, of a compelling argument to the effect that suicide is always wrong. I mean to say that it's morally blameworthy, nor that we must always try to prevent it. I think at best, we have strong moral reasons to prevent some suicides, and I suspect that we would do well if we thought a little bit harder about the difference between cases where we should intercede and those where we should not. I'll come back to this point. This is sort of now for something completely different moment, but another thing that I worry about a lot, which ultimately connects to how we try to prevent suicide. It seems a natural assumption that because some people are at higher risk of suicide than others, if we could identify people who are at higher risk, we could save lives by doing things that reduce their risk. And in fact, a lot of our clinical work is aimed at that. Every time one of my patients is admitted to the hospital, I do a suicide risk assessment. And I might do it again over the weeks that they're there. And I definitely do it again at the time they're discharged. Some of that is for medical legal reasons, right? But we also think that it matters whether the patient is at high risk of suicide by the time they're discharged. How do we do risk assessment? The vast majority of the time, it's clinical assessment. Used everywhere. There is, to my knowledge, zero data supporting its effectiveness, right? We as clinicians are not good at predicting who is going to die of suicide. You might say, okay, well, fortunately, psychological sciences have a solution. There are risk scales that try to quantify a person's suicide risk. Maybe we could use those. We've got the Beck Suicide Intent Scale. We have the CSSRS, which my hospital has implemented universally. But these aren't particularly good either. The CSSRS has a sensitivity of only 0.67 and a specificity of only 0.76 for predicting any suicidal behavior, not suicide death. Suicidal behavior is much more common than suicide death, as we'll see in a moment. And that's only over a 2-month period. And in a review of 52 scales, this is now a little bit older, 2017, the positive predictive value for a high-risk designation on any of those scales was only 5.5%. Again, for suicidal behavior, not for suicide death. It's much worse for suicide death. Clinically, the best predictor is behavior, but it's actually a very poor predictor. Just consider the relation between suicidal ideation, behavior, and subsequent suicide death. If you look at young adults, ages 18 to 25, this is data from the early 2020s, about 1 in 17 has suicidal ideation in any given year. That's a lot. But only about 1 in 100 engages in serious suicidal behavior in a year. And only about 1 in 10,000 dies of suicide in that year. So suicidal ideation and behavior do not strongly predict suicide death. Less than 1 out of 500 young adults with suicidal ideation in a year will die of suicide, and less than 1 in 100 who has a serious suicide attempt will die of suicide. Those numbers may still be alarming. 1 out of 100 young adults who is otherwise healthy dying of suicide is arguably, in fact, certainly too much. But my point is just that the things that we use to predict don't work very well. Another worry is that a lot of people who die of suicide never come to clinical attention. If you look at teens, only about 25 to 33% of teens who die of suicide had a previous attempt that was noticed by any clinician. So that means that 70% of them die of suicide at their very first attempt. If you look at adults, only about 50% of persons who die of suicide have previously been in contact with the mental health system. And in another one of our studies led by Hillary Kuhn, in 4,000 suicide decedents, only 50% had ever reported suicidal ideation or behavior that was documented by any healthcare professional. Admittedly, this was before we started universal screening with CSSRS. Well, there's clearly a solution. It's ChatGPT. We can use machine learning to integrate more and better data to get better predictions. And because we're worried about all those people who haven't come to clinical attention, potentially even apply this to large swaths of the population, catching all of those people we wouldn't notice otherwise, right? We might even get so good at this that we know that somebody is at risk of dying of suicide before they know it themselves, which I think is very uncanny. And I'll recommend Minority Report to you. Great movie. It's an okay. This is already happening. So one example, there are many examples, comes from our colleagues at Vanderbilt. A team there led by Colin Walsh, who's a bioinformaticist, has developed a risk modeling algorithm that they are now using in their electronic health record system to push reminders to clinicians to do additional screening. In one study of about 7,700 patients, they identified around 596 individuals who seemed to be at risk of suicide, and some of those were marked as needing interruptive clinical decision support. So the medical record stopped and said to the provider, do a suicide risk assessment, rather than just kind of recommending it to them in a less intrusive way. So they did a lot of risk assessments. Here's the worry, though. None of the individuals in the entire cohort died of suicide or actually ever reported serious suicidal ideation. So they used a really fancy algorithm that seemed to work really well, but it wasn't predictive of anything that we care about that much. Overall, current approaches to machine learning suicide prediction have a receiver operating characteristic area under the curve of about 0.9, maybe a little bit better than that. That's primarily in retrospective samples. There's not a lot of prospective research about this, and we should expect that it will be worse. Certainly, these algorithms could get better with more and better information. Healthcare records aren't very good. There are a lot of inconsistencies, and there's a lot of missing data that would be relevant to suicide prediction. I also worry that these algorithms are going to have drifting usefulness over time as the factors that predict suicide actually change clinically because culture changes. And certainly they don't apply very well across different populations. But the solution, of course, is just more and better data and more processing power and more GPUs. And you can imagine that we would integrate all the things we might learn about a patient. Their genetic data, we've collected some of that, proteomics, transcriptomics, facial tracking, measures of inflammation, ecological momentary assessment, et cetera. And that with all of that information, we'll get very, very good at predicting suicide. And here I'm going to say something very controversial. I think even if we can accomplish that, we shouldn't use it. To explain why, I'll do a quick bit of math. This should be familiar from your intro biostatistics course in medical school. Let's imagine we have an exquisitely good model, which is to say it has a sensitivity and a specificity both of 0.99. This is far better than what can be realized right now. And it works over a very small time frame, a week. Assume that we live in an area where the annual suicide rate is about 10 per 100,000 persons per year. It's higher in Utah. It's about 21 per 100,000 per year right now. It's a little bit lower here. Imagine, like I think is true for this healthcare system, we serve about 1 million people. If that's the case, and the suicide rate is what it is, then about 100 people in our population will die of suicide every year. So we want to prevent as many of those deaths as we can. We start using this model on a weekly basis. We would expect that there will be a little less than 2 suicides each week, although of course it's not uniform in its temporal distribution. So as we use this model, each week we have 2 true positives. We catch both of those people who are going to die of suicide, and that's great. But the problem is we have almost 10,000 false positives, which means that any positive test is 5,000 times more likely to be a false positive than a true positive. Our positive predictive value is only 0.002. That's not a system that I want to use in my hospital. And I guarantee that the Vanderbilt system is not anywhere close to this good. If you think about the statistics, you'll recognize that if we use this over longer time frames, it'll work a little bit better. But the positive predictive value of this model over the course of a year is only 0.01, still not very good. And it might work a little bit better if we use it in populations where there is enrichment for suicide risk. Does the failure of this model matter? I'm going to claim it doesn't. We shouldn't actually be using this model, and the good news is we don't actually need it all that much. Because what would a model like this justify us doing? I think it would clearly justify low-cost, low-burden interventions. Give everybody a safety plan. Great. Do counseling on access to lethal means. Great. It might even be justified for us to use population-wide interventions, like reducing firearm access, getting people trigger locks, putting acetaminophen in bubble pack, something they do in the UK, but we don't do here, would be very useful. Limiting access to insecticides, like they do in parts of Asia. But the trick is, all of those measures are justified anyway. We don't need the model to justify our doing that. I think what wouldn't be justified is additional screening. After all, we've already found the 2 people who were at higher risk of suicide. At best, additional screening is just going to identify people who have suicidal ideation, who are by hypothesis not going to die of suicide anyway, at least not over the next week. I think what's clearly not justified is mandatory psychiatric evaluations. It would be very unpleasant to have to meet with somebody like me, I think, and we shouldn't expose people to that unnecessarily. It would clearly be inappropriate to do involuntary hospitalization for all of those 10,000 people the model has said are at high risk. It would be very inappropriate to do involuntary medication or involuntary psychotherapy if that's a possibility. And I suspect it would also be wrong to limit their access to driving, to curtail their right to use firearms, although maybe we should do that for everybody, or to ask their family members to surveil them 24/7. So ultimately, I think we can say that our current approach to suicide prediction and probably near future approaches to suicide prediction actually just meet the definition of futility. The expected benefits of the practice are clearly outweighed by the expected cost or harms. I want to say a little bit about treatment. What should we do to support individuals who seem to be at high risk of suicide, especially given that we're so bad at identifying who really is at high risk? As you all know, there are some interventions that can reduce suicide risk. This has been well studied. Various kinds of psychotherapy like DBT, cognitive behavioral therapy for suicidal ideation, safety planning intervention, some forms of MI, calm, maybe different kinds of pharmacotherapy like lithium, clozapine for persons with psychotic disorders, possibly ketamine, possibly ECT, right? The list goes on. There are also different levels of care, varying from outpatient all the way up to involuntary hospitalization. One sort of overarching economical point, though, is that we have been doing all of the aforementioned things for a very long time. And in fact, spending ever more healthcare dollars on doing them. The chart here shows annual per capita expenditures on mental health care in inflation-adjusted dollars versus the age-adjusted suicide rate. And it really doesn't look to me like we are getting a handle on things despite our best efforts. This could, of course, just be because we haven't been doing it the right way. But that also implies that we should stop doing the things that we've been doing. I want to think especially about hospitalization. This is something that really animates me because I am a psychiatric hospitalist. Unfortunately, although we hospitalize many people to keep them from dying of suicide, there is very little evidence that it does anything to prevent suicide death. Just consider one study. This is published by Ross et al. In JAMA Psychiatry 2 years ago. They looked at 200,000 ER encounters, and they stratified people based on various risk factors, doing a kind of case control approach, and found that those who were psychiatrically hospitalized were not at all at a lower risk of dying of suicide or making a suicide attempt over the following 12 months. And there are many, many studies that replicate this kind of finding. It's also clear that hospitalization is not harmless. The average cost of hospitalization in Utah is about $1,600 per day. I'm guessing it's similar in other states. There are clearly opportunity costs. Many of my patients who are admitted complain that they're not going to be able to go to work, that it's hard to find childcare, that they're going to lose their house because they can't get access to their bank account to pay their rent. And unfortunately, that happens a lot. And if we think specifically about involuntary hospitalization, it is particularly controversial because there is some evidence that it actually increases the risk of suicide or is at least associated with a higher risk of suicide death. This might be because of the trauma that's associated with it. It might be because of the aforementioned negative externalities, the costs imposed on the patient. So when we consider how inefficient we are at identifying people who are at risk of suicide and how thin the evidence is supporting psychiatric hospitalization for suicide prevention, I think we can conclude that voluntary hospitalization to reduce suicide risk, although it's less aversive to the patient and maybe doesn't increase their risk, is still an inefficient use of scarce mental health resources. And I think it's fairly clear that clinicians should usually not involuntarily hospitalize patients who appear to be at high risk. There's no evidence that that is helpful. That said, I imagine cases where I would feel morally compelled to do it. The patient who has a gun, plans to shoot himself, and by hospitalizing him, at least for a short while, we can change his risk factors. Maybe that would still be useful. I do want to note that even if you agree with me, right, even if I could persuade everybody of these concerns, which I certainly don't expect that I will, it would still be very hard for us to change what we do. And I think one reason is that our field has a very strong pro-treatment bias. Some colleagues and I at the Baylor College of Medicine did a study where we looked at attitudes that psychiatrists have to psychiatric futility, as we were calling it. And we gave them 2 cases. We asked them to read the cases, both of which were extraordinarily treatment refractory, one borderline personality disorder, the other major depression, both patients presenting with significant suicidal ideation. And a substantial minority of the psychiatrists who completed the survey said that they would continue providing treatment for the patients, even though they had very little reason to think it would be useful for them. Right? So I think as a field, there's a way in which we have yet to come to grips with the possibility of futility in what we do. We might hypothesize about why that's happened. It could be that there are financial incentives. It could be that we have conflicts of interest. It could be institutional pressure or pressure from patients themselves or their family members. I certainly see that a lot. It might be kind of a primitive action bias. We just feel as physicians we have to do something. It may be that we don't really understand the risks and benefits and the balance between them of what we have been doing. It might be concern about liability. I think that's a big one. And then really importantly, and this is something we were talking about yesterday, it is probably continued hope for our patients, right? That even though we think objectively there's very little evidence that they're going to get better in these extraordinarily treatment refractory cases, that if we give up hope on them, we're guaranteeing they won't get better because hope is a critical therapeutic ingredient. So kind of coming to a close, I want to try to think a little bit about what would justify suicide prevention measures and what an alternative ethical framework would actually look like. To this point, I have hoped to persuade you that it's at least possible that we needn't prevent all suicides, that our efforts at prediction are unlikely to be helpful, and that many of our current interventions are ineffective. So if that's the case, how do we do better? What should be different? There are many people who think that we should just give up the business of suicide prevention entirely. This is coming from the critical suicidology movement. Many of the people working in this domain have had experiences of mental health care that they really, really disliked. And they say, in a nutshell, that everybody has a right to do what they want with their lives, whether that means dying or not, period. End of story. That elides a lot of nuance in their position. A 45-minute talk. This seems wrong to me. Think about Will. Even if we imagine that Will was an adult rather than 14, I think his suicide is something that we should have tried to prevent if we could. One clear problem with the critical suicidology position is that when somebody is obviously irrational, like a psychotic patient who thinks that if they die of suicide now, they will be resurrected in some better way, we should prevent their suicide, treat them. And of course, when somebody wants to die of suicide because of some kind of factual error, think of Romeo and Juliet, we should do what we can to prevent their death. A better principle might be Mill's harm principle. So Mill says we are only justified in interfering in others' actions to prevent harm to other people or to temporarily allow us to determine whether they are rational or ill-informed. So if you see somebody who's about to walk off a broken bridge into a chasm where they will surely die, you can stop them and you can say, do you understand what you're about to do? And do you know that the bridge is broken, that if you walk in that direction, you will die? And Mill would say that if they say, yeah, that's my plan, then you have to let them go. That doesn't seem right either. I think the harm principle is wrong. And the reason for that is that we don't, in general, accept that interference in suicidal behavior is justified only on the basis of formal irrationality or factual ignorance. It also matters whether a person's evaluation of how their life is going is accurate. When they think life is going so poorly, it would be better to die. If that judgment is reasonable or unreasonable, I think determines whether it would be appropriate to try to prevent their suicide death. So going back to Will and to John, again, obvious that we should try to prevent Will's suicide death. I expect it's controversial, but it's not as clear to me that we should try to prevent John's suicide death. Remember, he has gastric cancer and he's extraordinarily treatment refractory. He's unbefriended and he doesn't want to live. I think this is justified because Will gets it wrong about whether his life is valuable, but possibly John doesn't. He has actually made a clear-eyed and reasonable assessment of where he is. The difference between them fundamentally is a matter of how and what they value. We need to take that into account when we're making risk assessments and evaluating. So I would propose a different framework from what I think we do now. When a person seems fully capacitated, when their life really is going poorly such that they reasonably see little reason to go on living, when there is very little chance their life will get better, when their dying will not harm others substantially, then preventing their suicide through restricted means, you might do less restricted means, that would be okay, is likely to be wrong. And to just summarize, I think we should try to approach suicide prevention differently than we do. Suicide risk prediction is unlikely to be useful to us. I would stop doing it if my boss would let me. Some high-intensity interventions like hospitalization are unlikely to be justified. There's not evidence supporting their usefulness. I still think lower intensity interventions are suitable for widespread use, that are low cost, are likely to be quite useful and would almost certainly, if we use them more extensively, reduce suicide deaths, which, just to be clear, I think is still a good thing. And ultimately, we should strive to prevent suicides that seem to us to be irrational or unreasonable or reflective of erroneous values, but not necessarily do that with people who seem rational, reasonable, and whose assessment of their ongoing quality of life actually reflects the reality. That's all I've got. Just want to acknowledge some of my collaborators and funders, and thank you for your attention. I am happy to take questions, comments, dodge tomatoes, etc. Sure. Yeah. And he's got one.
Sure. Thank you. A very interesting and provocative talk. I was actually curious. So you made the comment that that factors that might predict suicide have changed over time. I would love to hear a little bit more, and whether, because that would suggest that we're just not doing it right. And I gathered from the rest of your talk that we're probably never going to be able to do it right. So I'm just curious what factors might have been in a 1980s scale that doesn't exist today and things of that sort.
Yeah. I want to clarify, this is a hypothesis I have, so don't have a lot of data to support it. But to give you an example that I think is plausible, for a time, the utilization of opioids for chronic pain was a risk factor for subsequent death by suicide. Opioid prescribing practices have changed dramatically in the last decade. And so the people who are getting them right now are in many ways different than the people who had been getting them before. And I would expect that if we looked at that data again, we might find that the relationship, the predictiveness of opioid use is different. Yeah.
Hello. So I'm interested in the moral and factual elements of this framework because I think that they're a little bit different. I'm actually probably one of the people in the room that you can convince on the moral side, but maybe not on the factual side. And so maybe I can give you a motivating example because we just had lunch. If I have what appears to be a hamburger in front of me, and I'm trying to decide whether or not to eat it, there are two sets of relevant questions. One is it better to be a vegetarian? And that's a moral question that I can be uncertain about, right? I can be uncertain about the sort of moral status of animals. Are they enough like humans that it would be bad to eat them? And then the second question is this real meat? Right? That's a factual question. And both of them matter for my decision. I think you can make a good argument that you might be right on all of the moral reasons why we should stop intervening in so many suicides. But don't you also present a case that you probably couldn't be right or couldn't be sure enough on the factual questions? To say that another way, doesn't your argument that we essentially can't predict suicide also kind of imply that we can't predict whether someone's life will be going so badly that we should let them end it? You know, those seem to be not identical, but if I'm bad at one thing, I imagine that I would also be bad at the other. So even if I agree with you on moral grounds, I'm worried that our factual uncertainty is so high that we might still be obligated to intervene no matter what. And the one final thing that I'll say is, like, this becomes even more concerning if we have asymmetric risks. So I might be more worried about a false positive than a false negative. Can you talk me through that?
Sure. Let me take the first question. So I take your point. There are two different intellectual tasks here: deciding what's right and then deciding how best to do what's right. Very clear. I think that the intellectual work involved in making a risk assessment where we're trying to predict who is at risk of suicide, predict what they will actually do, is actually very different than the task of evaluating with them where their life is right now and where it's likely to be going from a moral standpoint.
Can you tell me how?
In the second case, I'm not making a prediction. I'm making an evaluation. And the patient is making an evaluation.
And I'm not trying to be dense. I actually genuinely don't understand what the difference between an evaluation for whether someone's life is worth living. And again, I'm on board with you that there probably are many lives with net negative utility. But making an evaluation of whether your life has net negative utility, even including with you, is a forecast about what's going to happen over the course of the rest of your life. It is still a prediction.
It depends in part on such a forecast. That's true. Yeah.
I mean, more than just in part, like pretty centrally. And I'm not trying to be dense. I'm not trying to be. No. I think I'm probably closer to your position than most people in this room, and I wonder if you could help me get across the
true,
line.
I'm in real trouble. I think that you're absolutely right that if we're evaluating our quality of life, there's a way in which prediction is very, very important. Yeah, because fundamentally, one thing I'm interested in knowing is, what is my expected utility, right? Am I likely to realize the things that matter to me, or likely to have a lot of experiences that are bad?
Correct.
I haven't said at any point that we can't predict anything. We predict lots of things. I predict that I'm going to get a question from Kim in a moment.
Yes, and I don't want to cut her off because I'm interested to hear what it is, but I'll follow up with you after.
Yeah.
All right.
Yeah.
Okay. So hi, Brent. I promise I won't take up the rest of the time, but I will say, I think where I disagree fundamentally with you, and I think a lot of us in the CSPS would, is the idea of utility as a basis for suicide prevention. And I think if we think about the two cases, the vast majority of people who die will fit the second.
Right.
Most people who die by suicide, their lives do suck. They may have even contributed to their lives sucking, but they are human beings who are suffering. And the vast majority will also believe that their life would be better, that people in their life would be better off if they were gone. That's the central tenet of the interpersonal theory of suicide. So I think if we take your logic, we actually wouldn't prevent most suicide deaths. Most of the people who die are going to fit your criteria for not having, unfortunately, a life that is utilitarian, that's worth it. And I think even more sadly, every single older person I work with would fit your second example. Right. They are older, they have lives full of suffering, but I would say we can help them have a better death. We can help them not live isolated. And I think most importantly, if we take your framework, the vast majority of the people we're going to lose are you. We're going to lose the older white men who stop thinking they...
Hmm?
Not that old.
Who stop thinking they have value when they retire and aren't giving back.
Yeah.
That's who dies. That's George Eastman. He died because he retired and felt like he wasn't giving back. I don't want you or George Eastman to die alone of a gunshot wound. And I really hope that you don't either.
Thanks. I really appreciate those concerns. I think where I would disagree with you is in where we might be drawing the line. So it's not obvious to me that the majority of people who are sort of like John, case 2, who have a lot of really bad things going on in their life, actually would meet this threshold of utility, because we know that their evaluation can be distorted by their illness. We know that they might not appreciate the ways in which things get better for them. And although I think it's maybe more likely to be true for older adults that they cross this threshold, it's not guaranteed, because they might have lots of ways in which they're giving back in which they still find that their lives have meaning and purpose. So in a way, we don't disagree that much. I think I have a question way up at the back, actually. No, they're coming to you.
It's on. Okay. All right. While that's going up there, I'm going to paraphrase a question on Zoom that I also had. You do present evidence and support a variety of upstream, more population-based approaches. And we actually have interventions that show through pretty rigorous evaluation that they can prevent suicide deaths. Is this in part and partly through some gun means restriction that have one kind of effect, other interventions that might help people make their life more worth living?
Right.
Is there an ethical question about why are we, or the value of so much of our resources going into the very edge of the waterfall versus more of these upstream population-based, where we can actually, even if suicide isn't necessarily the outcome, we can help people to have some other positive benefits in their life at a population level?
Yeah, it's a great question. And there was a whole part of this talk that I cut out about the critical loss of meaning and how maybe the ethical imperative for us is to do what we can as a society to give people narratives and a sense of their lives where they actually are more meaningful, and where suicide doesn't merely seem like it's not an option, but actually isn't an option because their lives are going well and they don't cross that threshold. Absolutely important, right? A critical part of our obligation to other people. And to the extent that we're currently appropriating resources to do things that are both ineffective and which only address the sharp edge of the risk curve, we probably should reallocate those resources.
Thank you. And piggybacking off of that question, well, first, let me thank you for that presentation, really because it's relevant, given the New York State Medical Aid in Dying recently signed contract by Governor Hochul.
Yeah.
I think this is quite relevant, and so thank you for presenting this. My question is pretty simple. Your presentation loaded very highly on the rational and the cerebral way, a cognitive way of and reasoning through the suicide. We have cultures and societies that use affective and more difficult to measure constructs like hope and purpose and meaning. And my question is, where does that fit into your model, as I think it will be more inclusive of others?
Great question. Not a simple question at all, a very hard question. Of course, I do all this cognitive kind of intellectual stuff because I'm a philosopher. That's what we do. That's my particular handicap, I think. Where do all of these other ways of conceptualizing our lives fit in? I think fundamentally they are essential elements of how we think about whether our lives are going well. Attachment to community, a sense of hope, a sense of doing things that matter for others or which are valuable in their own right. All of those things are emotionally laden processes, and that's what gives our life meaning.
I think we've reached 1 o'clock.
Thank goodness.
Probably Dr. Kious will be here for a couple moments for some after. Thank you very much.